Well, hello, everybody, and welcome to this podcast, Future Directions in PBC Research and Management. I'm Christina Hanson. I'm a family nurse practitioner, and I've been practicing at South Denver Gastroenterology for a little over 18 years. And today I am joined by Patrick Horne. I'll let him introduce himself.
Thanks, Christina. Yeah, I'm Patrick Horne. I'm a nurse practitioner. I'm at the University of Florida. I've been there for just over 17 years. Happy to be here with you.
Yeah, absolutely. So again, thanks everybody for listening. Obviously, this is an exciting time for us in liver disease with PBC and research and the way we're managing our patients, the way we're monitoring our patients. I think I've heard PBC been called the most common rare liver disease out there, but it was over 20 years before we really had anything new for these patients, and we know that they're tucked away in our practices, and it's really exciting to have newer options for this patient population. So one of the things that we're going to be discussing today are these emerging biomarkers, these novel therapeutic targets that we're shooting for in PBC management, and we're looking at it in research. And one of the big population of patients that we've been looking at or studying is the global PBC study group, over a few thousand patients with PBC that we've been looking at over the last decade. And we've really seen a shift in the way that we're talking about response and more than just response, but adequate response, and driving that alkaline phosphatase to that normal range and in some providers' minds as low as possible. But I think we're seeing a shift not only to looking at the alkaline phosphatase and transaminases, but also other markers. And there's some data around looking at total bilirubin, GGT levels, albumin, along with the alkaline phosphatase, and showing that the longer that these markers sit outside the upper limit of normal, these derangements, and for a longer period of times, there's increased risk of liver-related mortality, morbidity. So Patrick, in your practice, what's the approach that you're taking these days with notably the alkaline phosphatase, but looking at some of these other markers? Are you kind of taking that into account when you're managing your patients with PBC?
Yeah, I think you bring up some good points. I think, traditionally and sort of, I think you and I were trained very, very similar that, it's really your focus is always on the alkaline phosphatase, which is still a very big, important aspect of PBC and management of PBC and a marker of response. But what we're finding with some of as these new drugs that have come out, what we're finding is that there are other markers, as you alluded to. So total bilirubin, albumin, GGT are probably just as important. Even the transaminases, AST and ALT, I think also play a role as well in markers not only of response, but also of sort of predictors of disease progression. And so what I've sort of done in my practice is obviously expand my focus to not just focusing on the alkaline phosphatase, but taking all of those into account, just as you would, other patients with other types of liver disease. And so you're looking at the alkaline phosphatase, of course, but you're also looking at what are the changes over time in things like GGT and total bilirubin. Where are they starting? Where's their baseline levels of those? And then what sort of changes do you see over time as you initiate therapy?
Yeah. Yeah. And I think there's still, especially in the community, still a lot of effort and education just needed around that shift in thinking about the alkaline phosphatase. So I think it's going to take a while for that to gain traction, and looking at these other biomarkers, I really want that message of trying to normalize that alkaline phosphatase to take root and become kind of a mainstream. So that's still a big push. And I think we say this in a lot of liver disease and when we make management choices, and especially when we're thinking about adding a second line therapy for a patient with potential side effects and potential cost, the sweet spot seems to be for that bilirubin, this less than 0.6, and normalizing that alk phos. But if I have a patient, it's 0.7 or 0.8 and pretty steady over time, and I have a normal alkaline phosphatase, and I think you have to think about that fibrosis stage as well. Am I going to add a second line therapy? Maybe not. In every scenario. But if I have a patient who does, at baseline show some advanced stages of fibrosis, I'm probably going to be a little bit more aggressive with that patient. So I think fibrosis assessment is a big marker as well for the way that we're managing our patients. In your practice, do you tend to, what's your go-to for assessment of fibrosis?
So we're fortunate enough that we do have access to FibroScan.
Mm-hmm.
And so I would say 99% of our patients do get a FibroScan. In a situation where we can't do a FibroScan or whatever the case may be, I might revert to a FIB4, but I would say the majority, because I have access to it, I do use a FibroScan as my baseline fibrosis assessment.
And a patient with PBC, especially, someone who has minimal to no fibrosis, do you repeat that periodically or a couple years, or do you reserve that for the patient that has more advanced at baseline, or both?
So I do. I repeat it at different intervals, I think, depending on where the patient, is at baseline. So if it's a patient with very mild fibrosis and let's say they have a complete response, they have a normalization of their alkaline phosphatase on whatever therapy they're on, I might repeat that FibroScan every 2 years, for example. Whereas if it's somebody who maybe starts with maybe some more fibrosis, F2, possibly, F3, I might repeat it more often, but probably I don't think I would repeat it more often than once a year, unless there's some other change that I'm concerned about. But I think, you have to, especially if you're assessing for disease stability or progression or possibly, regression, depending, I think you need to give it at least a year on whatever treatment you may have them on before you reassess. Otherwise, I don't know if you're really going to get any real helpful information.
The utility of doing it any earlier is probably not going to yield you very much information. And then one of the other things we wanted to talk about is this idea of personalized medicine in our PBC population, and addressing notably the symptoms that our patients can experience. In this patient population, not necessarily from the therapies, just the disease itself. They can have a lot of symptoms, extrahepatic, and pruritus and fatigue being the most common. And I think we're seeing this shift in the way, a bigger push to make sure we're assessing patients. I think these patients often seem asymptomatic, and if you don't have it in the forefront of your mind, digging a little deeper on asking them about the potential for pruritus and fatigue and their sleep, and how they're experiencing issues in that nature. And so I think there's a big push for a reminder just to be making sure at every visit that we're asking about these potential symptoms. But we're also seeing some positive data from the studies, especially with the recent approvals of PPARs last year, about the potential for improving this. So what are your kind of go-tos when you're managing patients? How are you assessing for pruritus and fatigue? And then what are you seeing kind of as potential future benefits when it comes to the treatments that we're looking at these days for managing our patients?
Yeah, so I think this has been, we've heard this at multiple conferences, over the last year to two, that I think we all recognize we don't do a good job overall of assessing pruritus and fatigue. And so I think the first key is you have to ask, and you need to ask at every visit. And there are a lot of, questionnaires out there. There's a lot of, patient-reported outcomes questionnaires that are available that probably don't get utilized very much in clinical practice. But I think simply asking and then just getting a very simple idea of, on a scale of 0 to 10, if you do have pruritus or fatigue, where are you? With the recent approval of some newer second-line therapies that do have data supporting improvement in pruritus with those drugs, even though they're not FDA approved specifically for pruritus. Behind that, there's lots of research ongoing on the IBAT inhibitors, and which are approved for other indications around that, but look to be very effective or seem to be very effective for cholestatic pruritus. So I think we've made huge strides from where we were, and then we've got even more coming down the pipeline that especially for those patients with sort of that refractory pruritus that's really severe. Because as you probably know, while there may not be a large number of patients who have that severity of pruritus, those that do, it is really impactful on their lives. It really impacts their quality of life. And so to have something now available that seems to show an improvement, and then possibly other things that will improve even further, I think will be just fantastic.
Yeah. To your point, I think the vast majority of patients that I see really don't complain or have issues with notably with pruritus. We're all tired, but with fatigue. But the ones that do, it can be quite debilitating. And to be able to, where historically we recognize that treatment did not improve the symptoms our patients had with PBC, pruritus, or fatigue, and some of those treatments actually exacerbated or could cause that. Now we're looking at therapies, and notably, as you mentioned, with the PPARs, in particular, having signals for improving pruritus, and then recently coming out with more data around fatigue. An improvement in fatigue. While that's not the specific indication, here's something that we can offer, even in the setting of fairly good biochemical response. Their liver function tests, ALK-phos, these levels are normalizing or improving, but there might be an indication to take on a second-line therapy that has these positive benefits for those symptoms that our patients experience. And as you said, a lot going on in research and how that may change the way we're managing our patients over the next decade. So it's really exciting when we do look at further PPAR. We've got the IBATs that they're studying specifically in PBC. They're looking further at fibrates. So there's a lot on the horizon, again, in a space that for so long has been fairly dormant. And unfortunately, these patients can advance. So a lot of exciting research around this population space. So exciting decade to come.
Yeah, and I think, going back to the whole asking about pruritus and fatigue, I think a lot of patients may not realize that they have fatigue or that they have some degree of pruritus until you ask them. And then that they just think it's natural, or it comes on so slowly, so insidiously that they don't really realize it until you bring it to their attention. Yeah. And then they're like, oh, okay.
They learn to live with their own norm.
Correct, exactly. Yeah. And so I think another important reason to address it, especially now because we have better therapies that we could offer that can help improve that.
Yeah, these are I like to say these are dry, itchy, tired patient populations. So it's exciting to have something to offer for them, and more to come.
Absolutely. Yeah, it's exciting. I think we're really seeing it's a rapidly evolving field. There's a lot of research, a lot of good research, and things seem to be moving in a very positive direction. Yep. So. Excited to see where we go from here. Yeah. So I think with that, we'll conclude, and thank you all for listening today, and thank you.
Yep. Thank you, everybody.